In today's episode, we are meeting with Dr. Amit Mahajan, otherwise known as Dr. Bobby Mahajan, and I will probably be calling him Bobby today. So great to have you, Bobby. Dr. Bobby Mahajan is nationally recognized as a leader in interventional pulmonology, and he is also the medical director of the interventional pulmonology program at Inova. We'll get into what interventional pulmonology is.
That's a little bit podcast, man.
Yeah. But he is board certified in interventional pulmonology, pulmonary medicine, and critical care medicine. His areas of expertise, and Bobby, by the way, at any point during this conversation, if we misrepresent what you do, please correct that.
Oh, I'll correct you. Don't worry.
His areas of expertise include procedures for diagnosing lung cancer, treating cancers within the airways, management of airway complications following lung transplantation, and a procedure known as bronchoscopic lung volume reduction, BLVR, for patients with severe emphysema. He also oversees Innova's incidental lung nodule program, which is essentially when a lung nodule is noted not with intent for looking for it, and lung cancer screening program. So it's a lot, I know, but we're looking forward to start getting Bobby to share with us what he does. So just to kick us off, Bobby, you can either restate everything I just said, tell us a little about yourself, and what kind of drew you to focus on the lung cancer side of things, lung research, care?
Sure. Well, thanks for having me, everyone. I appreciate it. I will say that I'm a kid from the Midwest who kind of slowly graduated out of the Midwest after I realized that, at 18 years old, there's not a ton to do in Toledo, Ohio. So I actually went to med school there in Toledo, Ohio, then was at in University of Chicago for 8 years doing my pulmonary critical care fellowship and residency. And then I did, and we'll talk about this, Sam, I did my interventional pulmonary fellowship at Mass General in Beth Israel. And that was kind of a subspecialty pulmonary critical care. I like TV, movies. I think like 13% of my brain is actually like reserved for movie quotes. And then
that way.
Yeah. And then I love my family. I have 3 kids and a lovely wife, and I spend as much time as I can with them. So I don't have a ton of hobbies except for work and my family. Like those are my hobbies. So okay. I don't know what's going to happen when the work thing slows down in the future. But no. I mean, if you look at what I do on a regular basis, it's a good question. I mean, if we look at what interventional pulmonary is, it has actually only been around for like 20 to 25 years. And in general, when we look at a pulmonologist or a critical care doc, they're focused on just general kind of diagnostics of the lungs, and critical care docs take care of people who are critically ill in the ICU. And in the past, there's been a small component of that, which has been procedural, meaning they'll do procedures on the pleural space, which is a space around the lung but between the chest wall, or within the lungs for biopsying different types of lung masses, at tumors that are in the airways, things of that nature. So maybe about 20 years ago, you started having these group of individuals, mostly in the United States, but also in Europe, who really focused on only doing the procedural standpoint. So it's like one of those questions of, all right, well, this person needs a bronchoscopy. Instead of just having the random pulmonologist do it, they say, oh, yeah, I always call, Dr. Joe Schmo because he always does these procedures, has gotten really good at them. So about in 2000 is when the actual profession really developed as having interventional pulmonology, of only doing procedures on the airways, within the lungs, within the pleural space. It ends up being relatively, I wouldn't say always high risk, but they're higher risk procedures because you're dealing with the airway in it usually. So what we've seen, what has evolved in the last 20 years is that the technology has evolved immensely, meaning that we can biopsy nodules that are 3 millimeters in size, whereas in the past, we were biopsying things only if it was about 3 centimeters in size. That's the only way we can get to them. We are doing robotics now. We have airway tumors that are blocking the airways that we can actually really endobroncally resect. But a lot of that comes to the fact that we're taking care of patients with cancer, mostly lung cancer. And it has evolved to the idea of, instead of just treating these patients and diagnosing them, is how do we do this kind of preventatively? How do we see patients early and catch lung cancers early? Because it really does come down to, lung cancer itself is very challenging to take care of and treat and cure, mainly because there are no symptoms when it's early stage, right? When people develop symptoms, it's usually because they're having advanced disease and they're getting symptoms because, tumors have moved out of the lung. So incidental lung nodules, lung cancer screening, things of that nature is trying to develop ways of finding these nodules early when they can be diagnosed surgically or treating with radiation oncology and actually curing them. The problem is, how do we find them early? And that's really what we've been focusing on a lot at Inova Schar, but also at the Seville Center as well. So it's a long-worded answer, but that's kind of what I do in a long kind of soapbox.
So let's maybe dig into that just a little bit more. So, anybody could be like, well, then I want to get screened because maybe I have it in its early stage, or maybe I have a nodule that I want to get checked out.
Yeah.
How do you think about the patients that should come and see you and qualify for that early screening?
Yeah, so that's a great question. I think we run into it's complex, like an onion, lots of layers there, right? So we look at what are the high-risk individuals for lung cancer. What we typically will look at who are individuals who should get screened are people who are between 50 and 80 years old, okay? They've smoked, and we consider a significant amount, and we call it 20-pack years. And that really means you multiply the number of years you smoked by the number of packs you smoke a day. So, for example, if you smoke 2 packs per day, if you smoked for 10 years, you multiply those two as 20-pack years, okay? Same thing as if you've smoked a pack a day for 40 years, 40-pack years. So someone above 20-pack years would qualify for lung cancer screening. And then last, someone who is currently smoking or has quit in the last 15 years. Okay, so that's what we kind of look at is the task force for lung cancer screening. Now, these are constantly evolving. So, for example, the American Cancer Society has actually said, look, in the near future, we're going to take away the smoked in the last 15 years, right? Because really, you can have plenty of patients who have quit within, prior to 15 years who get lung cancer. So that's about 80% of the people who get lung cancer are smokers. So if you fall into those 3 categories, meaning you fill all of those, you should get screening for lung cancer.
Should get screened.
Even more challenging now is we have a significant number of individuals who get diagnosed with lung cancer who have never smoked. So we have 20% of people with lung cancer have never smoked.
And are you seeing that that's because of pollutants they're exposed to in the field of work?
Yeah.
Just sort of
Combination.
Can't figure out why?
Well, combination, but for better or worse, we're starting to get more and more data. So I don't think it's new that it's been going on. We just never really paid attention to it. And part of it's because we just didn't have a way of knowing who they were. And as time has gone, time has kind of collected and we get this data more and more, we've seen that individuals with significant genetic mutations have a higher incidence. And the main one is what we call EGFR. Okay. And if we look at EGFR mutations seen in patients, they have a higher incidence of getting lung cancer. Now, the majority of individuals who have an EGFR mutation that leads to a lung cancer are Asian females. So the DMV has a significant population of Asian females. You also see in Asian males, and sometimes you see in non-Asian individuals as well, but the predominance occurs in Asian males and females. So you kind of say, well, am I supposed to get screened? Now, we look at the data longitudinally over the last 10 to 15 years when we've looked at lung cancer screening. If you screen everyone, you end up getting a ton of false positives, meaning that the lungs are one of the few organs that are exposed to the air, right? So you go into a bar, you go somewhere, Sam, I'm sure, has been exposed to all these things in bars, right? But, you breathe these things in. But you inhale something that's irritating, your body naturally creates a little bit of a granuloma or a wall around it.
Right.
And it looks like a nodule, right? So if we screen everyone, right, you're going to find a lot of nodules. And one, you're not going to biopsy them because they're low likelihood. But two, you freak these people out appropriately. They say, oh, you have a nodule. And what is our answer? Well, yeah, we don't know exactly what it is yet, so we have to get more data. The challenge even more so is that a patient who has a high risk for lung cancer falls in those category of a high risk patient who should get lung cancer screening. 26% of those people will have a nodule.
Yeah.
Okay, so you look at it, you see the nodule, and appropriately, they're a high risk person, they have a nodule. People get worried. Only 1% of those, that 25%, actually has cancer. Mm-hmm. So again, it becomes a situation where, don't get me wrong, lung cancer screening is in its infancy, right? It's only been about since 2011, so 14 years compared to breast cancer, colon cancer. But it's a hard kind of screening process to do because it's not just by age, it's by risk factors as well. So, we say, should you get screened? The people I recommend screening are, again, definitely the people who fall into that category. And it's a real quick, low-dose CT scan. We do them here at Inova all day, every day. And then the other group, because they don't necessarily fall into this high-risk category, we usually say people who have a family member who has had a non-smoking lung cancer, if you're a sibling, a daughter, or some of that son, we recommend getting screened. But unfortunately, again, guidelines are for people who don't do this every day, right? For us, we say that, yeah, if you have that risk factor, we want to get you screened. The insurance doesn't always cover that, right? So we are fortunate at Inova in Northern Virginia. We've created a kind of a program that if you want to get screened, even if you don't qualify, you're paying about $150 for the screen, as opposed to, getting denied. And other places around the country pay like $1,000 for a CT scan. So we're trying to make it easier, partly because it's just accessible. It's hard to set up a lung cancer screening program because it takes a lot of resources, but it's just the right thing to do. There's also this stigma around lung cancer screening where people who have smoked were like, look, either they don't want to know, or they say, look, I did this to myself, right? I shouldn't have smoked. One, smoking is an addiction. So it's not like something you just, you stop. Okay. People who can stop right away, more power to them, but it's very challenging. The second part is if you look at American culture, in the last, half the century, smoking has been part of like the fabric of what we do. Like if you look at Mad Men, for example, that TV show, there's fewer times where someone's not smoking in that show than they are, right?
Yeah.
And in the corporate world, in life, people are smoking. There were doctors smoking. We smoked on planes not that long ago, like 20 years ago, right? So, what I try and tell people is, look, this is not something that you're doing to yourself, but frankly, we can do a screen and we can find it early. This is curable. Early stage disease, 95% cure rate of 5 years. We just got to get them in and make it feel comfortable for them to come in and talk about it. So that's part of my job.
Going back to, thanks, Bobby. That's very helpful. And you actually answered a lot of questions already. So it makes it easier. So there's more actually piggybacking off what you're saying.
Yeah, I say no one listens to me at home. So like you guys listen, I talk.
We'll listen to you for the next 30 minutes. I've heard of it. We're going to listen to you. As you're talking about the non-smoking incidence of lung cancer, and I know it's a complicated question and you've sort of answered a little bit of the why.
Yeah.
Are we just catching more of these lung cancers in non-smokers because we're just doing more CTs? And is there a way to account for that? Like, okay, the percentage of let me just focus on incidental. That's one way to ask the question.
Sure.
Is the rate of incidental lung nodule finding that turns out to be cancer pretty much the same as it always was? We're just ordering so many more CTs, or are you like, no, even relative to that?
Yeah, no, also, great question. That's, that's a deeper dive into it. But really, if we look at data in incidental lung nodules, and like you said, Sam, you're totally right. It's a nodule that gets detected for when you're looking for something else. So, for example, someone comes in with chest pain to the ER, right? Everyone gets a CT scan nowadays because, again, CT scans give us a lot of data. It's not a bad thing, right? But you end up finding a nodule that we didn't expect to see, right? So in all honesty, if we look at the data, and we do a lot of data with incidental lung nodules here at Fairfax and Inova system because we just have a lot of patients coming through our ERs. We, in the last 5 years or so, we just submitted this paper for review, we have about 10,000 nodules that came through. And of those 10,000 nodules, there's about 1 to 2% are found to have cancer. Now, 1 to 2% of 100, not that many, but 1 to 2% of 10,000 is a lot of patients. The challenge we run into is about 15% of those are metastatic disease from somewhere else, which again, they didn't know about. We find a nodule in the lung and we diagnose it. It ended up being breast cancer or colon cancer, something of that nature. The rest of that other, 80% end up being primary lung cancers. And we broke that down a little bit further, and only about 30% of those individuals actually would have qualified for lung cancer screening. Most of it's by age. So that means that they are younger, right, than the 50 to 80 cutoff, or they're older than the 80 years old, so we wouldn't have screened them. But again, it makes you look at this even further, that about 20% of those people as well, just like we talked about from the numbers, never smoked, had no reason to have a cancer, right? We tested them once we diagnosed them, and it ends up being about 60% had an EGFR mutation. So I think that it's not that we're not looking for it as much. I think two factors. One, when someone had lung cancer and they never smoked, in the past it was like, oh, well, that's just a fluke. But now we're actually putting all this data together from different institutions that do a lot of lung cancer screening and IP and thoracic oncology. And like, oh my God, like we are seeing this 20% change, right? the second part of that is I think that, like you said, we're just seeing so many patients, right? And they're getting tracked. The problem is 85% of people normally, if they get diagnosed with lung cancer, is in an advanced stage because there's no symptoms, right? So when we
Even now in the increased incidental, is that statistic still hold now with the increased
so
with screening and
Yeah.
increased incidental finding? It's still about 85%.
So we've, again, looking at our data, we've actually done really well. 16% will get early stage. So if you have an incidental lung nodule program that's really organized and developed, it's about 26% are early stage. So you make that huge, what we call stage shift. You're early diagnosing them earlier. Again, incidental programs are not easy to develop. It takes a lot of resources, right? So if we can implement these, we shift that stage to earlier disease. But I think that what we're running into, unfortunately, is that with the advent of kind of understanding the genetic mutations that are associated with lung cancers, that's where it's really picked up in the last 15, 20 years. Like, oh my God, like, why are these patients coming in and not having lung cancer? The fact that we've established these mutation analysis that can show why, I think people are really starting to pick it up, because it used to be like, yeah, we can't do anything about it. You got lung cancer, like, it's terrible, but unfortunately, we couldn't look for this. Now that we have mutation analysis where we can say, look, if you have an EGFR mutation, you're a non-smoker, you're relatively healthy because you're a non-smoker, right? Sometimes you're just taking a pill as treatment with metastatic disease all over the place, and patients have better disease-free survivals, and sometimes these tumors just melt away, right? So it's a totally different world we lived in than 10 years ago. So we try and tell our lung cancer patients, and honestly, I have these conversations all day, every day, telling people they have lung cancer, right? Because we biopsy them. I know usually in the recovery area, based on what we saw in the room, that it's lung cancer or not. I talk to them, and this is the first time they're hearing they have lung cancer. I really do tell them, it's like, look, it's not a question of diagnosing you. It's getting the more kind of granular data about what your mutation analysis is. Because if your mutation analysis shows that you have one of these other, there's 7 or 8 mutations that are really actionable, you're going to do just fine. We're going to turn this into a chronic disease. Okay, it's not going to be the death sentence it was 10 years ago. So it has really evolved dramatically in the last 10 years to the point where it really is a question of not will we be able to diagnose you. It's like, yeah, we're going to diagnose you, but we got to get more information.
We're going to go a lot deeper than that.
Ton of that. And I think that's where we stop usually. People will stop from their mindset if they get diagnosed with lung cancer. Like, I have lung cancer. It's like, yeah, you have lung cancer, but that's like tip of the iceberg kind of stuff. The stuff we can do it at Schar, people didn't that can be done at major institutions.
Is that all our early stage identification, or do you even do that with advanced stage?
Yeah, so all of the mutation analysis, kind of how we treat that, is late stage.
Oh.
Right? We still look at it for early stage because, frankly, you never know in the future if it recurs, you'll be able to treat late stage disease as well with those. Early stage disease, the standard of care is still, minimally invasive surgery or radiation, because that's where survival is really exceptional. Right. Now what you really look at is, can we get you to a disease-free state? Meaning that you might have disease in your lymph nodes, you might have disease in your lungs, all over your body. Our goal is to try targeted mutation, which is a targeted therapy, so that you don't have the same side effects as chemotherapy. Try and clear it from wherever it can in your body. And then if we can treat with radiation or surgery that primary site, we consider that disease-free, right? And that's where a ton of people live. There's a lot of people living around that are walking around doing normal activities, functioning, and are in disease-free state because they benefited from these kind of different types of treatments.
And have you been doing these treatments long enough to sort of see, like, what's the lifespan of a patient that is considered disease-free?
So disease-free, it's super individual, meaning that some people, I know patients 10 years have had disease-free states, and they were diagnosed, started on EGFR drug, and again, they're getting checked on a regular basis, right? But they're not imminently dealing with the side effects of cancer. But the data will show that there's no improvement in survival, but there's an improvement in disease-free survival, meaning that the amount of time they actually have disease is minimal compared to the time they die, compared to someone who, again, had raging disease, unfortunately passed away early, but they were miserable and symptomatic. Right. So, we have a very, famous person that we've talked about here, and Neil Augustine has been disease-free for, I think, close to 3 years now. Doing great, advocating, but again, he came and I had seen him when he first came in, and he was a perfect kind of example of metastatic disease, was biopsied right away, got his results within 4 days of the EGFR mutation and got it treated right away. Is doing great, disease-free, you know?
So speaking of that, actually, that's a good, walk us through kind of what it's like for a patient who, maybe the incidental lung nodule program, right? An incidental, it could be either, maybe similar trajectories. Proper, like a qualified screening, what happens next? Or you get a call or follow up, perfect example, someone, like you said, goes to the ER, gets a CT looking for something else completely. They're discharged home doing great. Dr. Mahajan, we'd like this person to see you in your office. We found a lung nodule.
Sure.
How does that go? What's the timeline for that? What are the steps? And I know it's not obviously the same for every patient, but high level, like what does that look like?
So, I mean, luckily, again, we have a relatively robust research program, so we have all this data. We've looked at Inova to make sure that it is the best and the shortest amount of time for all that. So if you look nationally, in general, okay, if someone gets identified with a lung nodule, and this is crazy to me, but this is how the world works, unfortunately. If someone gets found to have a lung nodule, to diagnosis, the average is about 6 months, which is ridiculous, right? Someone comes in with a nodule, and again, depending on the size, there's
that's an average.
But if you
that's just because of wait times,
getting people in, wait times, I'll tell you, we look at the care continuum. Most places, someone gets a nodule for the ER. What do? Only 30% of patients are actually told they have that nodule or follow up on that nodule. So there's 70% of patients, they didn't even know it, right? Then they have to go see their primary care doctor. And the primary care doctor says, oh, yeah, you have a nodule. We got to do something about this. So what do? Understandably, they send them to an oncologist. Oncologist is like, I can't do anything until I get a biopsy, right? They send them to the person to biopsy. And it might not be the right person to biopsy because there's tons of us who do different biopsies. They finally get the biopsy. Again, they wait a couple weeks to get that biopsy. Then they go back to the primary care, who then sends them back to the oncologist and then says, oh, well, you know what? To actually know what to do next, we have to do another test. That's why it kind of just draws out for a long time.
Right.
So
and that's
6 months.
I think, stress point.
Dude, it's not even a question of...
If you hear that you have a C word, the fastest, the thing you want the most is to have quick answers and a plan.
You want to know, right? And the actual mental anguish that goes with it versus the procedures is like nothing, right? The procedures nothing, but the mental anguish is terrible, right? And then once you actually get diagnosed, depending on what it is, then you either go to oncology or you go to surgery radiation. Now, the terrible part about this is that 6 months, right? Every 3 months, you jump a letter in the staging, right? So, for example, if you were 2A, in 3 months, you go to 2B. And in 3 more months, you now graduated to 3A, which is considered advanced disease, right? So the amount of time, it really is critical, right? So this is why we found that 84% of people are metastatic. They might not have been metastatic when they first found to have a nodule, but they then can fall into that category for how long it takes to get in, right?
So is Inova doing things to shorten that process?
So we're incredibly lucky that we have the support to actually develop these. And again, we look at how do we find these nodules? How do we change that 30% to something that's more sustainable, like 90%? And luckily, our oncology department, our radiation department, and most importantly, and I can say this to the big man, Deacon has been very supportive of developing this. So if you look at this, if someone finds a nodule, say someone goes to the ER, they get a nodule on the CT scan, they say, well, whose job is it to follow up on that, right? Is the radiologist? Well, the radiologist is I make fun of them. They're in a dark room just hanging out somewhere reading films, right? ER doc is trying to see 20 people, right? So
Apologize to the radiologists.
So that's the radio. All right. So we essentially will then say like, all right, well, the ER doctor's like, look, there's no PE. Good. All right, great. Like and they're not necessarily saying, oh, there's this 7 millimeter nodule that we have to follow up on. So what we have and what is really state of the art now is that we have software that every time someone says the word lung nodule in a radiology report, it gets dropped into a bucket for us. And this was purchased by Schar. This is very high level stuff, and it either uses keyword searches, and newer software we're getting now has kind of special linguistic kind of technology that will find these even more accurately.
And this is within the health record. So meaning, let's use your example. In the last month, I'm totally making up numbers right now. 100 patients go through our ERs, get discharged. Lung nodule is noted on a radiology report.
Yep.
And let's, for the sake of argument, pretend that they didn't get a follow-up arranged or nobody even told them.
Totally.
This software within your program would catch.
Yes.
Yeah.
So someone logs into the
Yep.
computer, sees 10 patients, by the way, have rolled through our ERs,
Yep.
and they have a report that says lung nodule.
And that's about what we see every day. So in all the acute care kind of facilities in the Inova system, they will drop that into a bucket, and we have 4 different navigators who look through this every single day, about 10 every day. And they will then look at the size of the nodule, look at their risk factors. If it's low risk, the patient and their primary care doctor will get a note, a letter, and a message that this person has a nodule. Just to let you know, low risk, but it's something you should follow up on. Anything above 6 millimeters or so, or high risk factors, that person automatically gets a call and gets told, look, this nodule was found, you're in a high risk category. Either we can have you follow up your primary care, but what we have at Inova is a dedicated lung nodule clinic, an incidental lung nodule clinic. And again, like you said, what do people say is like, yeah, I want to get seen.
Yeah.
They can get seen that same week in the nodule clinic.
That's amazing.
Right? And
what is
so
the reason for the option?
the reason for the option is there's some people who say, look, man, I don't really, they might not be a part of the Inova system, right?
Okay.
They came from somewhere else.
They're like, good to know. I'll
follow
I
up.
have this other resource. I'll make sure I follow up.
This relationship.
And a relationship
Yeah.
with my primary care doctor,
Yeah.
no problem, right? So we say that's not a problem at all. We just want to make sure it's taken care of. So if you feel comfortable following them, and they get the report, they get a letter as well. Okay. And frankly, our navigators will contact their primary
Yeah,
care if they
so
want,
that's-
right? So we have like the nicest, most outgoing navigators I could possibly imagine. We're very lucky, right?
And
They'll
what's the
go that
timeline for this, Bobby?
within 48 hours. So most
So
of the
the
time,
offer for an appointment in the incidental lung clinic for the high risk / greater than 6 millimeters,
correct.
would be 48 hours
Correct.
in the incidental.
Correct. Either they will go to our PA clinic, which is typically on Mondays, or my clinic on Tuesdays and Thursdays, right? So they get in right away. And the reason for that is, again, you need to be able to risk assess them. You need to stratify them. But our ER docs also know about this program. So I can't tell you how many patients who are literally, they'll get a CT scan. It shows, for example, a 4-centimeter mass, right? And they're outpatient. The ER doc will call us and we'll see them that day in clinic,
Yeah.
right? Because they came in for some chest pain.
Yeah.
There's it's not heart related, but there's a mass. They'll just come over to Schar and get a diagnosis.
So no longer is it 6 months.
No.
It can be 6 hours.
So yes.
Well, and they were taking so that, to your point, the timeline is obviously a crucial part of this, right? Both because of the psychological effect that waiting so long can have, but equally importantly, the fact that cancers grow, if it's in fact the cancer.
Yeah.
Right.
But you're also, correct me if I'm wrong, taking a lot of the complexity of healthcare out of the equation.
Totally.
You're not putting on the patient or the constant redirecting of, is it the oncologist? Is it the primary care? Is it the pulmonary doctor?
Yeah.
The program sort of takes that on and you say, you just land here and we're going to navigate this for you.
Well, and that's where it comes down to. Is like literally we cut out all of the confusion because again, I'm not going to lie, it's hard to be a patient coming on the ER with a diagnosis and you're supposed to follow it up. It's very challenging. No matter the best health system ever, right? But you're waiting regardless because health systems are busy. So we really cut out the middleman. And I will admit, the way I look at it is like, this is the best thing for the patient, right? Not all docs love that I'm like, look, we're calling your patient and we're bringing them in. But it's the right thing to do.
It's the
right?
right thing
It
to
is.
do.
And
The patient likes it.
so the patients are very happy. And so we look at our finding the nodule to diagnosis time is about 40 days, right? Now, I still think 40 days is high for me, right? The challenge ends up being not so much the getting the patient in, the biopsy, but sometimes the patient be like, look, like, I want to wait a little bit.
Yeah.
I want to look at this. Like, I'm not ready to go for a biopsy tomorrow, right? There are
What's the fastest looking for fastest for a renal, other than to say, remove that out of the equation.
Yeah.
So assuming a patient who is on board, ready to go,
What would
you're
you
immersing.
do?
Yeah.
What would that timeline look like?
It can be 5 days. So there is a patient
That's great.
that last week, and again 2 weeks ago, ended up having a nodule. It was actually more. I would say it's a mass. Had a brain lesion. The reason they came in is because they were having a tremor that was all of a sudden new. We saw them on a Wednesday. They had some cardiac issues, so we had to get cardiac clearance.
Yep.
We biopsied them on Monday. My pathologist, Dr. Amin Benudas, Ram's Romanian as well, they have really fought hard to get all of that testing that's done in-house. So we can do an EGFR test at Inova, whereas
Sending it out.
Yeah, right.
most
Hear about that or sending it out. Back in
most places in the country outside of like major academic centers, it takes about 3 weeks to get those mutations back, which again is terrible, right?
Yeah.
Got the EGFR mutation back for the patient.
Yes.
Back on Wednesday, she started on Tarceva, which is the treatment, that EGFR pill, on Friday, right? So we have the capabilities of it. And, we don't toot our horns enough from an oncology. Our oncology docs are amazing. And it is one of those situations that I say, look, Ram, I biopsied this person. They have cancer. Can you see them tomorrow, right? They literally would be like, yep, put them in. And I actually messaged me last week. I'm like, all right, there's a patient. Can you see him next week? He goes, why do you want to wait till next week? I'm like, brother, fine. Well, let's get him in. Like, they'll see you in 2 days, right? So it is one of those situations where, is doing the right thing is not always the easy thing to do. Like, you got to fight. You got to build this infrastructure. And we've spent 10 years building this infrastructure, right? So now when it comes to lung care, not only from an oncology standpoint, but if someone needs to get resected, again, I will call someone in the recovery area that it's early stage disease. It's in one spot. I'll call Mike Wyan, my partner, and he'll get them in the next week for surgery, right? So it is treating not only the disease process, which is important, obviously, but the mental part, the kind of the treating the family, because they don't know what's going to happen. You don't want to wait 6 months to have that happen. You want to know right away. And again, in some ways, we make it a little less sustainable for the staff, right? It's hard on the staff. Like, I tell my coordinator, like, can we get them in tomorrow to biopsy them and see, the oncology department and surgery next week? They're like, dude, you don't have any opening.
They're making miracles happen.
And it is, but they find a way, right? So it is a full team, right? The doctors, again, don't get me wrong, we're there to do what we are trained to do, but none of it happens without all the staff in Schar. I'm making sure these things happening, right? Like and it doesn't mean just people in Schar. Like, again, I need to get cardiac clearance. They got us cardiac clearance with our cardiologist in a day, right? They know that this time is of the essence. They know that it was on their side. We would do it for them. So it really is a very unique, not only program, but like institution we work in right now. Yeah.
So we are just about out of time.
Oh, crap, sorry.
I know. That's...
Yeah. I do that a lot. I talk a lot. I'm sorry.
No, it's been really great information. And I think it would be awesome. Leave our listeners with just a soundbite. You covered this earlier, but what should they take away from this? If they're hearing this and they're like, gosh, am I at risk? Like, how should they be thinking about that?
I think that, one of the biggest things for a patient to do is to advocate for themselves in a lot of ways. Meaning that if you are concerned that you might be at high risk from a smoking standpoint, whether it's, 50 to 80 years old, again, 20 pack years, quit in the last 15 years, or currently smoking, talking to your primary care doctor about lung cancer screening is essential. But also, feel free to call Seville. Call the hospital, be an advocate for yourself. Say, I want to come in for lung cancer screening, right? The second aspect of that, I think, is that, again, we know who the high-risk individuals are. But if there's a problem or you're concerned about these things with risk of lung cancers, risk of any cancers, we have the ability to research this, look this up. And Dr. Google can be challenging sometimes, okay? But I will say that if you're curious or you're unsure, you should feel comfortable enough with an Inova physician, an Inova oncologist, anyone, to ask about that, right? Is this something I should do? And we can give you a data-driven kind of response. But at the end of the day, I really think advocating for yourself, and if you're worried about something, whether it's oncology related or non-oncology related, you should feel comfortable talking to your doctor about that. And if they find a reason that there is a risk, we will get you in as fast as possible, because we know it's not just about the disease state. We got to treat the mental state. And again, not just the patient, but also their families as well.
Thank you so much. This was so insightful.
Yeah.
Thanks, Bobby. That was great. We appreciate it. You did talk a lot, but honestly, like I said,
to be home.
but honestly, you answered. I mean, you really, whether it was stopping and us asking 50 questions or you answering them all with 5 questions, it really is incredibly helpful information. So hopefully our listeners get out of this what I got out of it and what Tracy, I'm sure, got out of it. So thanks again, Bobby. Make sure you listen to our podcast.
I will. Well, I'm on it.
And thanks for coming.
All right. Thank you. Have a
good conversation.
Yeah, I appreciate it.